We are going to begin our webinar in 1 minute.
Brought my little brain.
Good afternoon, and thank you for joining us for today's webinar, Remote Scanning Opportunities and Challenges. Before we begin, I would like to go over a few housekeeping items. Today's webinar will be recorded and available through our website. To minimize noise and distraction, all attendees' mics have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using our Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Garry Carneal, RadSite President and CEO. Thank you.
Well, hello, everybody. We're really excited to be part of this roundtable discussion today, which is going to talk about remote scanning, covering trends, opportunities, challenges, and a little bit about accreditation. I'm excited to introduce a little bit of our esteemed panel. Again, my name is Garry Carneal. I'm the president and CEO of RadSite. I've been in that position for over a decade. With the remote scanning accreditation program, it'll be the 30th accreditation program that I've brought to market. So I'm looking forward to adding some color commentary along the way. Kevin, you want to introduce yourself?
Yes, I'm Kevin Oliver. I've been in radiology, seems like forever now, but I've been around MR since it came out. And now I'm with SimonMed Imaging and been there about 20 years. We've watched all the changes that we've done. And now from going to, it was still some film early on, limited stuff. Now there's nothing. And just seeing the whole evolution of radiology. And it's just amazing where we're at now. So my background's been in imaging for that time, mostly in MRI, and that's where my passion is.
Great. Thank you, Kevin. Dr. Siegel?
Hi, Garry. Thanks. I have many passions. I've been affiliated with the University of Maryland and Department of Veterans Affairs for many years. And as it says here, I'm the Standards Committee chair for RadSite. And most recently, I've pivoted to join United Theranostics. And so it's great to be here. Thanks.
Great. And Dr. Tanenbaum?
Hi, Garry. Hi, everybody. I'm just a country doc, just struggling to get by. I'm currently in the end of my 9th year at RadNet, watching over their advanced technology, but I have 20 years of background in clinical practice and private practice, and about 8 years in academic practice, watching over the same type of processes at Mount Sinai. And I'm happy to be here with the rest of you folks today.
Great. Great. And just a little background on RadSite for those of you who don't know. RadSite is an accreditation body. It's been in the advanced diagnostic field since 2013. We offer 5 accreditation programs today related to CT, MRI, nuclear medicine, and dental and medical cone-beam CT. And hopefully later this summer, we'll be offering our 6th accreditation program on remote scanning. So more on that later. So we're RadSite's pleased to be able to sponsor today's webinar. So today we're going to cover, I think, some key topics related to remote scanning. Obviously, it's been a topic that's been fairly hot across many different professional societies and in the imaging field itself. So we're going to start off today talking a little bit about remote scanning models. What does that mean? What does the term cover? Talk a little bit about the professional staffing requirements associated with the remote scanning, what's going on. Drill down and talk a little bit about the opportunities that remote scanning represents and the challenges that are before us in terms of as we move forward in standardized practices across the country. And then we'll take a little bit of a sidebar and talk about the RadSite accreditation program We originally had a policy that was adopted in 2021, and now we're on the final leg of developing an integration program. And then we'll take some questions from the audience and talk about next steps. So I'm going to start off first with Kevin. And Kevin, maybe you can kind of tell us a little bit about what this concept of remote scanning covers and what it means.
Well, let's start with the history of it. So, you know, the ability to access a machine, an MRI, CT scanner, even other, has always been there. You know, engineers have been using it almost since since MR has been around. They've had to have remote access. And then once COVID kind of hit there, we realized we had to have some way of still continuing to offer this service. And so that's kind of what prompted remote to take off here in the last 4 years. But just like many things, it was very COVID driven. So we took that, and then once we were doing it and said, okay, this is going to be great, then we realized all the things you can do with it. So you talk about the models. So you can use it to remote scan for staffing shortages now. So if we don't have somebody sitting there, if you can have somebody that's qualified to do the positioning and all that, you can. We use it for doing education. You have a technologist on that's having a case they don't know how to do. So you use it in adjunct to their other training, and to continue that and do exams that normally couldn't be done, you can get on until someone's trained and comfortable. Before, if you were going to, let's use an example of doing breast imaging, you would have to, and the place was only doing 1 or 2 a week, how could you get that tech trained? Well, now you can get them trained because you can have remote in and go over it each time until they get comfortable with it. Then I think, so then you take it onto that, protocols. A lot of us are large imaging companies now with a lot of scanners. How do we keep control of the protocols? Then being able to log in and change and make adjustments and say, verify that it's the right way. So in all of those different ways to improve the quality that we have. And I think that's where it's going. And again, we started with thinking it was just going to be for a temporary time during COVID. Now we found all these other uses, and staffing is one of them. With the staffing shortages that people are having, this allows us to continue offering that service and providing better exams for the patient. You know, one thing we all use is temp services and stuff and come in. These people don't know our protocols. They don't know our routines. And so we can have somebody look over them and show them and keep them moving in the right direction until they're comfortable with it. So that's where I look at it. And I think when we're talking about the different scanning models that we can, but what's important is that how that setup is, and especially when it comes to where we're scanning the patient remotely and using that as the tech being the person doing the scanning. I think there has to be a lot put into that, what the safety of it is and how we do that. Coming in to show somebody a tech that's already certified is one thing, but going in and having someone else that's positioned your patient and done that, you've got to make sure they're trained, they're where they need to be, just so that, because safety is paramount in this, in any thing that we're doing, but mostly in scanning patients, it's remotely is safety. And that's what we're all well aware of that are on this call right now.
Right.
Or this webinar.
So one of the interesting things is the concept of remote, right? So basically for remote scanning, what that means is that the scanning technologist is not co-located with at the imaging console with the patient. So that's the notion that they're where the patient is in the imaging system, that's the originating site. That's a concept from telemedicine, and then the distance site is where the technologist is. And Dr. Tanenbaum, obviously there are different places where the remote technologist is. Can you talk a little bit about that from that perspective in terms of what remote means for RadNet?
Well, first, what remote means for me is when I'm trying to find ESPN on my TV thing here, and you know, depending on what cable system, it's always confusing. So
It must be difficult to do that, being a country doctor and being way out in
that's where I'm out in the
too. I
country.
guess
It's,
remote
we
has a
only have
different
4
meaning.
channels.
Yeah.
We only have 4 channels. It's
Yeah.
always a challenge. So, I mean, I'm not exactly sure what you mean, but, you know, remote for us is pretty straightforward. You know, we're not at the site where the patient and the aide is. You know, some of you folks who've been involved in MR, you know, since, the prehistoric era, which is what Kevin told us was he was there before when it all started. You know, we evolved into a situation where there's an aide, an assistant, and a technologist working side by side. In my mind, what we've done here is taken that scanning technologists and move them away from the aid and put them somewhere else, usually in a command center that for us may have 2 or 3 people working there side by side, running things. In theory, you could be anywhere in the building, in the same building, in the same facility, in the same campus, but for us, it's always somewhere else, and generally at a command center.
And so, Larry, when you say command center, so that means that you guys have a setup specifically designated where there are workstations or PCs, and there is connectivity in an area where people come into the office. And so just a couple questions. One is, does everybody work at the command center, or can somebody work at home? Because, so many of we radiologists are working at home. Is that possible for the techs, or are there technologic issues related? And then, are there any issues doing this across state? In other words, do I need to be in the same state? Or, to my knowledge, there have not been any comments or regulations. But do you guys always do it from the same state?
Well, I warned you I was a country doctor at the beginning, so maybe one question at a time.
Sure.
So let's go back to the first one, which was command centers. Yeah, they're generally sitting in a place where they sit in front of a dedicated workstation. And for us, it means at least 4 monitors dedicated to running scanners, plus the usual ancillary monitors for interacting with the wrists and the like. So that's our basic approach to things. On the other hand, we, the way that the structure is set up is that if we have a technologist who is maybe our lead tech for the region, with a laptop, she can stop, or he can stop at a Starbucks and jump right in and do whatever assistance needs to be done. So, and even as an extension from that, there's nothing that stands in the way from having any of our supervising physicians who are watching over, say, the MSK for the day or the body for the day, that they could use the same technology to log in and check. I don't know that we've done that in any extensive amount at this point, but it's part of the process. Now, again, you talked about across states. As far as I know, there are no restrictions for doing this operation across states. Like in many things in medicine, it's where the patient is and where the scanner is. Where the person is pushing the buttons and driving the scanning process isn't necessarily relevant. We haven't seen any of that. I think I got all your questions. Which
yeah, and just as
let me add to that. I'm sorry,
Sure.
Garry.
Thanks.
Kevin.
So I just want to add that, so for us, the model is of letting people remote from their homes, if that's it. And the reason is, and I'm going to use Louisville. Louisville's got a 3D place that does, a company that does 3D processing for, different people send in, do that, right? So in the Louisville area, you quickly lose a lot of techs and availability. So I wouldn't want to, with the tech shortage, where are your experts? Where are your best techs? We might not find all of them in one city center area. So, but there may be people in other states that are really, really good at doing what they do, that's who we want to bring on, and that they might want that to be, that's why I would want to do that work. So I can get an expert, and I think it opens the field of me finding more absolute experts that can do it, that know multiple machines, than if we try to limit it into there. So that's more on our model, is to find the experts where they're at and let them do it from their location.
And both of you do it only domestically, right? You don't have any command centers or people at home that are running the scanners from outside the U.S. at this point. Do you think that would be feasible?
Eliot, the bandwidth in Saint-Tropez is very limiting.
Yeah, although not necessarily in Paris or Rome.
You never know. New York's pretty bad. I wanted to follow up with a question for, I haven't done anything internationally. Kevin, I wanted to follow up on your comment, because when my guys sit at the command center, they've got a pretty elaborate setup. That's not the kind of thing you'd set up on your living room couch. And while you can log in from a laptop and give assistance, I don't know that I would feel as comfortable driving all day long practice from a single screen on a laptop. Do you have an opinion on that?
We send so when we get these, we set up a great computer with a great graphics card with multiple monitors, 27, 32-inch monitors. So when it looks like a rad reading station, really, that's what we have set up. And there's that cost of sending that to it, but it's not just doing off one unit. So they can have it where they could have their schedules up on one, the other they can have the scanner, the other they can have the cameras where they're seeing the patients and what's going on. And again, they're all, you know, well versed in HIPAA, and they know the rules. No matter where you're at, you still have to be cognizant of HIPAA. So that's how we do that. Just in again, just using a good setup for them so that it's not just a laptop type of thing.
Yeah. So just a quick note that when we get to the RadSite accreditation standards, they do cover both types of remote models, where you perhaps have the command station within the building, or the remote technologist actually, you know, offsite at a different location. Dr. Siegel, do you have any thoughts or observations as the standards committee chair on kind of just generally scanning models and different practices? I guess one issue would be, you know, what is the scope that we've addressed at RadSite in terms of the different modalities that are covered by remote scanning?
Yeah, well, so at this point, the modalities that we've covered at RadSite have been MRI and CT. And the interesting things from an accreditation perspective, you know, are that there really is kind of a new position, this remote scanning technologist, that we need to define in some ways and determine whether there are any different requirements for that remote scanning technologist. And in general, the requirements really are not different for the technologist. But then we have a position of an in-suite assistant, which is a position that we have not yet defined with regard to accreditation. And then there's always the question of supervision of the remote scanning technologist, and who is the radiologist that supervises that person. And so, you know, we have a number of additional staff. There's the supervising physician who supervises the remote scanning technologist, and that may depend on the type of scan that's being performed at any one point. And yeah, up here, Garry, you have the in-suite assistants also. The medical director is just a general descriptor of the physician responsible, and that cuts across all the accreditation organizations and, of course, the technologists. And so, you know, we've needed to think about and refine a definition of this in-suite assistant, and that's been something that we've needed to do. And then also, you know, because when we're talking about a physical on-site location of the technologist versus non-on-site, one of the intriguing things, of course, and one of the major advantages of remote scanning is the possibility that if you don't have to be on site or in suite, you can supervise more than one examination essentially concurrently. And so the potential to be able to do that creates some additional questions with regard to accreditation. And so those are some of the interesting differences that accreditation brings up. Overall, there are huge advantages, and I know we'll talk about those, of being able to do remote scanning, but it falls outside of the classic paradigm that's been set up for the accreditation organization. So it's been a really interesting challenge, you know, working with Kevin and Larry, and working with the committee to look in depth at how to do the accreditation in such a way to maintain safety and maintain quality and efficacy. And so it's been a fascinating learning experience for me, because within my own clinical practice, we've not done remote scanning yet, but or really, you know, looking into it very carefully.
Great. Dr. Tanenbaum, any observations from staffing from your perspective related to oversight or operations?
Entirely sure what that question means. I would say that in terms of staffing, we had a lot of pretty widespread clamor for the remote position from our technologists. We had no trouble filling that spot. I would say that what we found interesting is that nobody wanted to do it 5 days a week. So we found that our best technologists stepped up and wanted the job, but wanted to also have some shift time working at individual centers dealing with patients directly.
Why is that, Larry? Is it perceived to be more challenging or stressful, or?
You know, I just think, you know, people, you know, if you are an imaging technologist, you're used to being in a patient contact situation, right?
Uh-huh.
You're comfortable with people, you're comfortable with dealing with people. And I think the sudden absence of that and dealing with computers in a sterile room, it just wasn't appealing enough to give up the patient contact. So I think we found, and I wouldn't be surprised if everyone else finds the same thing, is that they want to work a hybrid job with, mostly remote, but they want their shifts at the actual site.
Kevin and Larry, do you believe that most of the technologists that you have are qualified to do remote scanning, or is that something that requires something extra? Would the typical?
That is a provocative question. So let's look at it. Let's look at it as the ideal. Ideally, anyone who's working at a site is going to be qualified to work off-site. It's really the same interface, the same process. In reality, however, with the shortage of technologists that we have after the mass resignation from COVID, with the trends of increasing volumes, more and more competition for personnel, we find ourselves with a lot more young and inexperienced technologists who work at our sites. So I would say the longer answer to that question is we aspire to have everyone working at our sites qualified to run the operations peripherally. But right now there's a reasonable stratification between the super experts we have training and supervising and driving remotely, and between them and sort of the newest end of our fleet. But I think for the most part, our aspirations to have anybody qualified to do this.
Is that your experience too, Kevin?
It is, but what I've decided, like, there's three things we look for. Somebody that can multitask, right? So if you have things moving on that. The other thing is you want technologists that are multi-vendor, because we have so many different ones and you don't want them to be limited by that. So that's important for the right candidate that we want to come into doing that. And then thirdly, silly thing, they got to have good bandwidth wherever they're at, right? For our model that we do it. And we want them to be, the top of their field and to be really, really good at it, to be experts and to know what they can do, because they have to make quick decisions when they're, because they've reviewed the orders, they've got everything down. And if something doesn't look right, and again, they have to know how to troubleshoot across all the vendors for whichever one they're logged on to, because we don't just have a tech that's assigned for GE scanners, or we try not to. Every once in a while, you'll have to do that and have somebody that comes in and they're just comfortable with that. But I'm sure with Dr. Tanenbaum and everybody else, there's multiple vendors that we have. They're running on different software levels, and they may have different coils and everything. So the remote tech really has to be an expert on that, because they have to adjust to each place that they may cover. And so that's kind of what we look for, somebody that has a lot of experience, that's an expert, and that it's multi-vendor.
And if I'm planning on setting up a remote program, would you recommend that I have a different pay scale for those technologists that are doing the remote scanning, or not necessarily?
Well, yeah, we'll watch how I answer that question, because I think that when everybody was doing the work from home, they said it's about an $8,000 a year benefit of not having your car, the mileage, all the stuff that goes into doing that.
Yeah.
So you balance that out so that person doesn't have to leave. And again, this is our model. There's that savings that's built into it. But you're right. It's something we debate in ours. Should the person doing remote be on the same pay scale, less or more? And I'm just going to kind of punt on this one and not really give it an answer now, because
sure, and it's so early
case by case situation, right?
Yeah, interesting.
So obviously, Kevin, you're a technologist, and one of the things we talked about was that there was a fear by technologists of remote scanning, but I think actually once they embrace it, they see it as a career, professional opportunity as well, right? Because there's, for example, a shortage of MRI technologists, so it's actually gap filling. So it really is a positive rather than a negative in terms of professional growth for a technologist, correct?
Well, I think also it's the technologists that were a little bit of naysayers and stuff are seeing the benefit when they get into a scan or a study they don't know about, and a person can remote in with them and help them. So they see that benefit of it, that, this really does work. And that's kind of, Dr. Tanenbaum and I were having a discussion. I think that's where the perception's changing now, and everybody's seeing that it is really a benefit, and it isn't getting rid of the jobs. It's making even the techs there better, but we're really more or less just filling a void as far as staffing part goes. So it doesn't affect that kind of job. It also, in training people and getting them better, we're able to backfill a lot of our own by using the remote to train some staff to come on and become independent techs that know how to make the right decisions. And you can spend more time with them that way than you can if you had them sitting at a center and you're trying to pay 2 full-time techs sitting at that same center and training for 3 months at a time. That's not a good value for you. A good value is to get the person where they can be and have somebody that can remote in with them. That's on that model again of being the support versus the staffing coverage by itself, if that answers your question.
Yeah. So RadSite spent a lot of time talking about the qualifications and training criteria for the in-suite assistant, in part because there's not like a series of certification programs you can get for that. What have you all done to actually train in-suite assistants to, basically be able to be at the console with the patient, and what's kind of their scope of their responsibilities?
Is that for me again, Gary?
Well, whoever wants to take it, why don't you?
Okay.
Yeah, you can start off.
Well, I mean, it's both. So, we do 2 things, MRI and CT. And for MRI, it's really level 2 safety training. Everybody's got to know which is standard before you would go into zone 4. And so we have to reinforce that. That's, again, safety is paramount to all of this in CT or that. So you want to get that part down, make sure they know nothing can go into that scanner. Then, and when to ask and to make sure that everything's being reviewed. The second thing is, back to CT, is there's a lot more to training in that. It's the IV training, it's the setting up the injector. There's a lot of stuff to do there. And so in doing that, we would never just take anybody and do it. We take a qualified X-ray tech, and then we put the time into them working one-on-one with the technologist at a site until they get up to the level that they're comfortable with that. Then we can come in and have someone work with them after it. But it's once that they've received adequate training. I mean, the only thing they're not doing by that point is using the scanner itself and setting up the parameters and making adjustments. All of that's then coming from the remote person. But so that's for our model with SimonMed. That's kind of what we want to do, is make sure that they're completely ready before. So it takes a little longer with CT. MR is we just hammer home safety, safety, safety.
Dr. Tanenbaum?
I was going to say something. I'm a little foggy minded right now. It's kind of the end of my workday. It's been a long workday for me. I would say that when we started this, and just to give you some perspective, we started well before COVID doing these processes, which was very helpful because it was our instant response to COVID. And but we started well before in terms of making this stuff work. And
Larry, when you say this stuff works, we're talking about in-suite assistants. So did you guys have in-suite assistants before you did? Okay.
I'm going to get there, Dr. So we started well before this. And again, what I was about to say is, and I got derailed, was when we started this, our biggest concern was diluting the safety barrier. We think of MR safety and MR screening as like the Swiss cheese model, right? Every level along the way, and anybody in medicine knows the story where the medical student takes the history and the attending comes in and it's completely different. Each level of the organization will screen. We screen at scheduling, we screen at the front desk, we screen when we walk you back to the scanner, and we screen when we walk you into the scanner. And we've all had those chilling circumstances where the last person who spoke to you as you walked into the room was the one who found out that you had an aneurysm clip or a pacemaker and the like. So we felt very strongly about that being the most important criterion. So we send all of our people to tech school, essentially giving them all the appropriate training. But it's not just safety training, because everyone in our facilities, from the patient service representatives across to the janitors, have MR safety training. These guys have to be trained in coil positioning, cable safety, body positioning against the console, right? Pinch points. I mean, anything you can possibly imagine that goes on, because they are taking over that part of a tech's responsibility, like you do in general practice, where the tech stays at the scanner and the assistant goes in the room. It's the same thing, but now they've got all of this responsibility for them without a direct supervisor in the room with them. So that's been part of it. We send all of our people to tech school and we maintain their education on a continuous basis the same way.
Great. And Dr. Tanenbaum, you mentioned you started the remote scanning program well before the pandemic. What were some of the opportunities you saw regarding moving to remote scanning for RadNet?
Well, you see that's a great question, because I mean, what COVID did was create a crisis, right? We suddenly lost a lot of people, but the situation was always in imbalance all along, because again, MR volumes, CT volumes continue to increase. There aren't really enough people in the field, to perform all these operations, to keep all these scanners open. RadNet had facilities that may not have been operational at any given point in time, because we didn't have the staff. So we saw this opportunity coming really, really early, which is why we were gearing up and providing this type of service even before the pandemic. But it's only, it only got exacerbated when we started losing people, to retirement and urban flight. But that opportunity to keep facilities open, to deal with people calling in sick, was really one of the great things that we're able to take advantage of with this type of remote staffing. But the ancillary part of all of that is we end up with younger, less experienced technologists, and the ability to support them. It became a critical benefit. But I'd like to look at this from a slightly different perspective. Right now we're really focused with retention, right? Lots of different things that we can do in our practices to keep our employees safe and supported and happy where they are, rather than looking elsewhere. And one of the most stressful circumstances as a physician is being an intern, not knowing what to do and being left on an island. Well, it's not much different for a new technologist being asked to scan an exam they're not comfortable with. Maybe they're not really 100% comfortable with cardiac. Maybe they don't know how to troubleshoot a prostate. And, ordinarily you leave them out on an island and they're stressed. And then they get yelled at when they fail. Whereas right now we support them and we prevent the failures. And that's a big benefit and a big opportunity for remote operations.
Great.
Let me just go back. I wanted to say that, yeah, Gary, we too send them to a bridge school that sets people up if they want to move on in and get their advanced certification, like in CT. So we want them set up because we always wanted educated people working in whatever we had them doing. So we wanted them to be prepared for that. So even if it's somebody that was a medical assistant that won't become onto it, we still have them take that kind of training. So they have, as Dr. Tanenbaum was saying, that they have more of an in-depth understanding of what's going on. And so that helps. And Dr. Tanenbaum was right on one more thing about the way we did teach techs before was you did it wrong, slap their hand, and then do it again. But now we can be proactive and catch those things and actually do some good training. So that's a good point, Dr. Tanenbaum, I agree with.
Well, thanks for agreeing with me. We all of us on this committee know I love hearing that.
Oh, I know.
But there is one more thing I'd like to mention, because it is really, as testimonial to the success of this process, is we've had several of our in-suite assistants go on to train as full technologists. Inspired by the activity in the field and the satisfaction they had from being at work, they've gone on to train and become fully registered imaging technologists.
Okay. Dr. Siegel, do you have any perspectives on the benefits or opportunities with remote scanning as chair of the steering committee? The work group convened about a year ago. Obviously, we've been dealing with this issue. Any thoughts from your perspective?
Yeah, I mean, I think from my perspective, it's really a continuum of the metrics and parameters that we want to collect from various sites, whether they're doing remote scanning or not. I mean, my questions as the head of the standards committee would be whether or not remote scanning essentially maintains the same level of image quality. My question would be whether or not patient safety is preserved. And so looking at safety and efficacy, the question is there a process that is taking place at the facilities that are doing remote scanning to be able to collect those data and to be able to internally create a way that the facilities can feel confident that indeed quality is being maintained or improved, and that efficiency is being maintained or improved, as well as efficacy. And then what there needs to happen is a continuous process where these facilities, just as they would do for non-remote scanning, look at the remote scanning, end up fine-tuning the remote scanning process based on the parameters that they're collecting. So I think it's really important, and I've been really heartened to get feedback from a number of the providers that are doing remote scanning, including Larry and Kevin's practices, where they have been collecting those data, comparing remote scanning outcomes with the outcomes associated with non-remote scanning. And it's been really interesting and exciting. I'm surprised that there has been so little published on this topic, given how much remote scanning there is. And so, I've been excited at the prospect of being able to take some of those data that are being collected by some of the large multi-center practices and to be able to share that in the imaging literature so that, we can essentially document what those improvements are associated with remote scanning and document what are the requirements for continuous quality monitoring and quality assurance.
May I add something here?
Sure.
We talked a little bit earlier about the reaction of the technologists in the community and in our practices to this process. You may find it interesting that we got the greatest pushback from our physicians. In a big practice with, which is, corporately oriented, the first question that came back to me is, what are you doing here? Are you trying, is what you're doing going to dilute quality? So part of our initial and ongoing process is always been to monitor the quality. And it reassured everyone in our practice that our data tends to trend slightly towards better quality and easily makes non-inferiority work. And you'd say, well, how does that work? Well, it should be better in theory if your best technologists are driving, right? The only reason it trends down to equivalent levels of quality is because they have challenges that you don't have at an individual site, which is we're operating multiple scanners. The protocols are slightly different between radiology groups. Maybe one group prefers one angle, another angle. So essentially our callback rate remotely is the same as it is locally, but in my mind, that's disappointing. And we've looked into the reasons, and it has to do with protocol variability across the practices. And we've used that as an impetus to try and reduce that.
You both mentioned multitasking. And so one question that I have is, do you find that the number of concurrent studies that one technologist is able to supervise, able to scan essentially, is similar for CT and MR? And are there numbers that you guys have as far as practical recommendations based on your own experience, realizing that there's not any right number and it really may depend on the study, the technologist, modality, center, et cetera. But have you had experience to suggest whether or not the average number of studies that a remote technologist is supervising is 2, 3, 4, 5? What's been your experience, and is it similar for CT or MR, or does one or the other tend to need to allow a greater number of concurrent studies?
Kevin, why don't you? I think you might be better suited to take this one, but I'll fill in if you like.
Well, so when I'll go with CT can be done more because look how fast the CT scan is now, right? I mean, it's beep, and you've got 624 images, right? With the multi-row. So that's so fast that the techs tend that they can go from one to another with that because you just don't have, you're not there waiting 2 or 3 minutes for a sequence to come up and see how good it looks. So you're more real time on it. I always use CT if you pictured a long hallway and you had a bunch of CT scanners lined up and the remote person would be going in the first room and doing it and then leaving there and going into the second room, and then everything else could be taken care of for that. So I think CT just by design can go. When we first got into it, I thought it would, I didn't even realize that it was just something that we'd said, well, CT as fast as this is a good thing. Then for MR, I don't like to give specific numbers because, as you said, it varies with the kind of patients you have. If you're doing a lot of breast imaging where you're confirming the fat saturation is good and stuff, that takes a lot more focus than if you're at a center that's an MSK practice and doesn't have any contrast and you're going straight through it. So there's variability based upon that part. So, but I think most people can do probably in an hour 4+ MRs, and that's very conservative. It's more than that, I think, but again, you have to look at what the center, where they're covering, contrast, not contrast. Are you doing a lot of abdomens where the breath holds and things, and verifying, as I use the breast as an example, where it takes a little bit of adjusting for that, and you want to focus on it. Do you have a tech that's logging on somewhere and they're helping with a biopsy remote or something? So that can vary. But I think if you put into it, a regular tech scanning can do 2 an hour, right? That's 1 every 30 minutes is what the average is. They may do 4 1 hour and the next not, but let's say that 2, a little over 2 an hour could be an expected average of that. So at a minimum, you can double it, but you should be able to go a little bit more than that. Again, depends on what that practice is. Eliot, we just have to always look at that and see which center's doing what. I mean, we have centers that are more geared toward breast imaging. So if that were to happen, then again, you wouldn't give that person, you'd almost let them just focus on that center and getting it done. So,
Dr. Tanenbaum?
Well, this is a very, very interesting and provocative question. Let's just say in 2024, RadNet is set up for 2 scanners at the same time with an option for 3. And we generally are working with more patients per hour than what I've heard described, but it's really about how many scanners they can operate simultaneously, and it's in the range of 2 to 3 for right now. RadSite as a group was
For both
meticulous
MR and
about,
CT, right, Larry?
we're not operating CT remotely in any great extent. We do just do some guidance and education on CT, but we're not actually operating any of our centers yet that way. The need wasn't anywhere near as acute. Now, you knocked me off my train of thought there. So I was about to say RadSite was meticulous on not limiting the number of simultaneous cases based on today's concepts. I think that was wise. The main reason I think it's wise is that our scanners are becoming more and more automatic. They're becoming more and more self-driven. And one of the things that you will see over the next few years is that will progress quite rapidly. Right now, if you have a scan assistant or a dot engine or or an exam card, the scans basically scan themselves, right? You start the scan, you verify quality, but they scan themselves, and it's only going to get more and more automatic. So while I think 2 to 3 may be a practical limit that we want to be at today, I don't think that will be the case forever. And I can tell you that you can already look at systems right now where they have essentially automatic scanning modes, where you essentially say hello to the patient, and that is all the operator intervention for that study. All the positioning, all of the scans, all of the processing, all of moving from scan to scan is all handled automatically. And we're really only maybe a short period of time away before the scanner itself will be able to assess the quality, the completeness, the adequacy of the positioning, and the absence of artifact.
Yeah, Dr. Siegel, you want to address how RadSite is covering caseloads and scanning in our standards? I mean,
essentially what RadSite's committee has suggested is, and I strongly endorse it, is that we don't have any particular recommendations for numbers, and that's really the responsibility of the medical director and also the supervising physician. And so that number, as we mentioned, can vary tremendously depending on the practice, the type of studies that are being done, and the technical specifications of the equipment that's being used. And so I don't really think that there ought to be a particular number that's set up. I think we can get great information from the experience from Larry's practice and Kevin's practice, and use that as guidelines as what has been practical. But we really don't believe that there is any rationale at this point to set a particular number limit.
So essentially, you're saying, I'm not sure I heard you say it, is you leaving it to the discretion of the medical director in the practice, yes?
Indeed, yes. That's a great way to summarize it. One question I had for both of you guys is, you said the impetus for this was, partly the pandemic and partly the shortage of technologists, which is pretty ubiquitous, admittedly. But based on your experience, would you still do remote scanning for cost effectiveness and improved efficacy if in a future point in time, there were not a shortage of technologists. And Larry, I know things are getting more automated, and futuristically things will change. But leaving that aside for a second, based on your experience, is it that we have this because of the expedient nature of the fact that we have shortages of technologists, or now that you've done it, would you actually continue remote scanning in a future environment where things reverse and we have plenty of technologists?
Well, that's an interesting concept. I'm not sure we're going to get there while I'm still practicing. So I think we're going to have that discrepancy forever. I think ideally, cost-wise and expertise-wise, you would want to concentrate, you would want to extend your best technologists to the greatest numbers of scanners. So it's kind of an ideal mode. I thought
Right. So it's not just because of the shortage, but
no, I just
because
think it's the
remote
ideal way to
scanning
go.
offers advantages quality-wise, subspecialty expertise-wise, and also efficiency and cost-effectiveness.
Right. I'd like to add one more point because I think this is important, and I think it's a unique observation. We did this, it became critically important during the pandemic, but as we come out of the pandemic and things are easing, what's happening at RadNet? We've got double the number of remote operators, and we're doing more than double the number of remote scans. Now that we've recovered, we've got our staff, it just shows that there's the mismatch between demand and capability and ability is not changing. It's continuing to be there, and remote operations seems to be the a viable solution for it.
So of the studies that you're doing, the MR studies, 5% are done remotely, 25%?
Well, I don't know the answer to that, but I will tell you that the eastern part of the country is doing about 7,500 exams per month.
Okay. So a lot of
I don't know
scans,
our overall numbers.
and it's definitely still a minority, though, a limited minority rather than majority.
I think it's definitely a minority. Yeah.
Okay.
Well, I mean, you can have, I don't mean the 8,000 a month. That's 100,000 a year. That would be a very small percentage of the exams that we do.
I see. And Kevin, is that true? Is it a small percentage?
No, it's still smaller because, and that'll lead me into the answer to your question, which is, I still think that an on-site tech, because is the better option. I think it's more efficient. Here's why. If I've got the tech's off-site and he's with, again, this is if everything was great, we had enough staff, was your question, right? We didn't have the staff.
Yeah, I mean, I've heard so many advantages. I'm wondering whether I should do it, whether or not we have a tech shortage.
Well, if the reason I would say that is if you have a tech, you've got the person putting the patient on the table, you're paying that person there, right? But you don't get the same efficiencies if you have two people. An example is, that's why techs, a lot of people went to a tech assistant things on site with people so that they help get the machine set up. One gets them, they're done scanning, they're taking the patient out, the other person's setting up everything, and they can come back with a patient. I think two people working on a scanner is more efficient. So in the remote access, you don't have that because you have the one person that's there, and then you've got that technologist away. So you're going to lose that. So your empty scanner time, I think, goes up. And so that's just my take on it. I think we could be more efficient if I had a tech with someone sitting there with them. Then I would still want somebody that could remote in, because that tech still may not have all the potential that could help them on difficult exams. But I'm saying if our staffing was, as of today, given the scanners we have, not in the future, not anything else, as of right now, I would prefer to have a tech and an assistant at a place if it was a super busy place. Because remember, you have a certain amount of no-shows and claustrophobic and all that. So you've got to really overbook, just like airlines oversell seats. So you've got to have people around that can keep the patients moving from point A to point B, onto the table, off of the table, and yet you're still giving quality patient care. Go ahead, Doc.
I'd like to add some controversy here. We're doing a little Saturday Night Live routine.
Great.
I think the ideal would be to have the people off-site. I think it's going to be economically much more viable. One tech and one slightly inflated salary will cover more than two techs, at any given point in time. I think I would say that and bearing in mind what I told you about where scanners are going, I actually think the remote model is more and more going to be the preferred and standard model.
Interesting.
Right. And I think
so
I
as
agree
to
with
the
him.
point,
Like I say,
Go
I
ahead,
agree with
please.
him on that. I was just going,
Yep.
if everything was, we had enough staff, we had enough, people, everything was staffing good and all that. That's it. But past it, and that's not going to happen, as Dr. Tanenbaum said, while he's still active. It won't happen while I'm still active. So this is the model that it's going to have to be, is what we're doing now.
Kevin,
And
you're only about 40, man. When are you planning on retiring? 45?
So
and with regard to the credit,
Okay.
to the train has arrived, clearly you guys this is a part of your routine practice and so many other practices also. And that's really been the impetus for the question about, creating specific remote scanning standards. And so, the accreditation organizations, as they are looking at current practice, need to update their standards to take into account, the really interesting and unique aspects of remote scanning. And so I think it's more than past time for an accreditation organization to essentially create standards so that we can maintain that quality and efficacy that we were talking about. So that's really, a strong argument for why it makes sense to do accreditation. And
Yeah,
that has been the impetus for us to create a remote scanning technologist policy in 2021, and now to essentially have revised standards that are expanded and updated in concert with conversations with CMS. So,
yeah,
Garry, did you want to add anything
Yeah,
to?
well, real quick.
I'd like to add something there before we go on, because I think it's in the same vein. I think it's important that when a standard like this is written, that it comes with a full understanding as to how things are done in practice. And what I think RadSite has done here is they really looked at the way things are done and put the appropriate framework around it, as opposed to an ideal situation, idealized, not ideal, but idealized situation or an imagined situation. These guidelines are built to address things as things are really being done in practice.
And when you say
We
really
haven't
done
rushed
it,
in. Sorry,
go ahead.
we haven't rushed into this. RadSite's been meeting on this for quite some time. Since, Garry, what year did this first get tabled or put
Well,
up?
we first started working on it in 2020.
So yeah, so this has been, it's nothing we've rushed into coming up with these standards. Everybody's tried to think about every possible, curveball that could be thrown at us for this, of what would make it safe and be effective, and be able to say, if you've got this standard, then we know that you're able to provide that service remotely.
Yeah, we've talked about stakeholders, including the patients, the technologists, the radiologists, and others. One stakeholder that we haven't talked about very much are the vendors themselves. And so to what extent do you both see advances in technology from your vendors that are providing, these technologies? You'd mentioned briefly, Kevin, that there had been the capability all along for the service folks to be able to remote into the scanners, not to operate the scanners, obviously, but to essentially connect in. And so are you seeing advances and improvements from the vendors themselves in providing relatively comprehensive support for your remote scanning programs?
Well, if you look, both Siemens and GE just got their remote abilities, FDA approved. So you see which way they're going with it. They might not have been on the same train, but they're there now. So I think they're going to keep doing it because they want to see it on their business side, not to have to use a third-party vendor to come in. And so they're all making theirs vendor agnostic so that they can come into each one. Siemens is more of it that, but GE's new product, Philips' product that they use can be across anywhere. But
so currently, you guys are not home growing these remote systems. You are using established systems from vendors, and you mentioned FDA clearance. It sounds interesting to me that FDA is clearing remote scanning systems as well.
Go ahead, Dr. Tanenbaum, were you going to say something?
Yeah, that was kind of an awkward transition to jump on there,
Yeah, that was a weird transition
at the end. Yeah, interestingly enough, is that this has been done before FDA approval. I mean, the FDA clearance. The vendor that in my mind, Siemens came first and did it for many years before they achieved clearance. Philips, I'm not sure they've gone for clearance. And it's nice to hear that GE, who was really last to the table, has gone for clearance. But let's talk about what I was going to mention beforehand, is that the tools we've had to date have been relatively crude. They've been essentially the same thing that your IT guy dials in with. And that leaves a few gaps here and there. And as these companies have evolved their tools, they've evolved them, to the point where you can talk directly to the patient through the user interface. And I think that's a big improvement. And while the individual vendors are building these tools and people are buying them, companies like RadNet are looking to integrate these capabilities into their overall ecosystem, AI driven and otherwise, and may very well build their own to make these processes customized and more tailored to the actual needs.
Yeah,
Interesting.
Let me jump in. We only have 5 minutes left. I want to save a couple minutes for questions, but I wanted to just share with you. This kind of reminds me of a recent experience I had about 8 years ago, where I worked with the American Telemedicine Association, and I was able to basically help develop a telemedicine telehealth accreditation program that became kind of the preeminent standards. And that was before, as telehealth was taking off, and there was ambiguity. So the nice thing about accreditation for the United States is that it can create that standardization without stifling innovation, help provide some leadership. The very first accreditation program I brought to market back in the 1990s was for PPOs, before anybody knew what a PPO was. I really think that the ATA and its efforts created the typology for telemedicine. So I think that we're going to back into a lot of these specifics. We're going to have a second webinar, which will get scheduled, that actually goes through the accreditation programs. But I am very excited about the dynamics. We've only been able to cover some of the topics, not all the topics, because there's a lot of aspects like the actual specifics of the technology, the communications platform. But I just wanted, before I turn over to Kristen, to kind of see if there are any questions. We definitely, RadSite, as evidenced by this webinar, wants to promote public policy discussion. We're going to announce next week or launch a remote scanning industry survey. All of you who are on the webinar will get a link for that. We hope you fill it out if you're involved in the remote scanning program. We'll report that to basically everybody to further discussion. Our goal is to finalize the new remote scanning accreditation program over the summer and launch in early fall. And we continue looking forward to working with people who may have different opinions as well, just not those that are supporting of it. So I want to thank the speakers briefly. Chris, I want to see if there are any questions that came in.
Yeah, it looks like there's some great questions.
Yeah, there are a couple of questions. I think one may have been addressed, but the first one is, how does contrast administration, oversight, and reactions fall with in-suite staff? Does anyone want to take that question?
Well, I can go ahead, Dr.
Eliot. You can handle that better, I think.
Well, one of the things I have to say is that the core accreditation, whether you're RadSite accredited or ACR accredited, needs to be a fundamental building block. So the remote scanning is on top of that. So, for example, RadSite is still deferring to the protocols published by CMS on the supervision administration of IV contrast. So you can still need the qualified personnel, whether it's a technologist, physician assistant, nurse practitioner, to oversee the administration of the contrast. We're still fine-tuning a couple issues that we're going to be working over the next weeks on the particulars. But I don't know, Dr. Tanenbaum, Dr. Siegel, Kevin, whether you have any other thoughts on that?
Yeah, I mean, in many ways, it really, as Gary's pointing out, is similar to the overall requirements if you are not doing remote scanning, that there needs to be somebody within the in-suite staff or within in proximity at the center who would be able to handle contrast reaction, administer intravenous contrast, and have oversight of that process. And so we're not changing any of those requirements with remote scanning. Any other comments, Larry or Kevin?
Yeah, I think you stated it well. The injection, we're not doing injections remotely, right? We don't have our in-suite assistants trained or certified to do injections, so it doesn't come up for us. If we're doing injections, we'll need someone on site, and often with a multimodality place, that's not a challenge. Who is trained and who has the appropriate qualifications as a healthcare personnel to do that.
Great. Kristen, next question.
Okay, yeah, and I see that a couple of questions have been answered by looks like Dr. Tanenbaum. So one other one is, what are the qualifications or training requirements for the in-suite assistants? I feel like we may have addressed that during this conversation. So let me go, this one's an interesting one. What happens when your command center goes down? All 3 units that are controlling all go down and multiple sites and patients are affected.
Well, it's interesting. There's lots of redundancy, right? I mean, if indeed we lose the communication, we've got other types of communication, instant messaging, Spark, FaceTime. You know, all of those are there as redundancy. I was sitting at a site one day in Long Island, where over my right shoulder, there was a remote operation of a 1.2 Tesla Fuji scanner. Over my left shoulder was a 3T Siemens scanner, and both of them got transiently interrupted. And the team immediately transitioned very quickly to going to SMS or going to FaceTime. You know, it was basically maybe 5 or 10 seconds of transient interruption. So yeah, if the internet for the entire East Coast goes down and nobody can communicate in any way, then that's difficult. But otherwise, if you have phone service, if you have internet service, instant messaging, FaceTime, as well as the actual operation, these things will happen. They won't happen simultaneously as in this cataclysmic example, but that's how we cope with it.
But you would not be able to do the scanning process per se, right? Because the scanning is done remotely by the tech. So if that command center went down,
Well, you know,
SMS.
I mean, theoretically, you're already in auto scan. You know, once you set up a scan, typically in a 15-minute scan, there's maybe 5 minutes of programming, and the
For
rest of
MR.
it is you're in coasting mode.
Yeah,
You know, if we're in coasting mode, things would continue.
understood.
If we weren't, we would have to stop, because it's very important to understand the in-suite assistant is not scanning. Okay, they aren't scanning, they aren't trained to scan, they don't participate in the scan. They deal with the patient safety, patient positioning, MR issues, but they're not scanning. The person who is remote has 100% full responsibility for the scan. So if they get disconnected and they're not in auto scan mode, scanning would stop until the connection came back.
Thanks.
Kristen, I
Okay,
know we're at
great.
the time. Is there any other kind of pressing questions you think we should? And we certainly will try to respond to everybody by email afterwards if we don't get
Just,
the question.
yeah, I will reiterate the email so people can email us if they want to, when we can get back to them with answers for the questions that we didn't cover today.
But great questions. Thanks. We appreciate
They're
it.
fantastic,
Appreciate
yes.
everybody tuning in. Yes.
All right, Kristen, go ahead.
Okay, so RadSite would like to thank our moderator, Garry Carneal, and our presenters, Kevin Oliver, Dr. Eliot Siegel, and Dr. Lawrence Tanenbaum. And if you have additional questions, please contact us at info@radsitequality.com, and we'll get back to you with answers to your questions. Just a reminder that today's webinar has been recorded and will be available through our website. If you enjoyed this presentation, be sure to check out the webinar page on our website and RadSite's YouTube channel for past webinar recordings. We hope you will join us for our upcoming webinars. And this concludes our webinar. And we thank you so much for joining us today.
Thank you.
Thank you. Appreciate it.